Good morning, everyone, and thank you, sir, for giving this opportunity. Uh, Today, my topic is aviation ophthalmology. So, I'm speaking about aviation ophthalmology, silent points. Okay. Silent points which are come routinely to our practice. So, before going to any medical estimate, we need to know for which class the aspirants had applied for. So, this is basically class 1 and class 2. So, what is class 1? So, class 1 is commercial pilot license. So, we encounter during the, if you are going to the any catching the flight, the pilots itself is a commercial pilot license holder, and second one is airline transport pilot license, and third is private pilot license. And class 2 is basically student license, which they are going for the any training and for small aircrafts. So this is the type of medical examination we do. The initial issue is in AFCME, IEM, and MEC Gerard. 3 centers are there. And from 45 years, every 5 years, there is a renewal. So this is our just like PME. And from 60 years till 65 years, there is not 1 year, it is every 6 monthly. And post temporary unfit cases, every case comes to us for in AFCME, IEM, and Gerard for disposal. So this is kind of visual task any pilots need to perform out in daytime or nighttime. Ophthalmological examination is governed by Aeronautical Information Circular. This is called AIC, and this is governed by DGCA, Director General Civil Aviation, and Manual of Civil Aviation, and it is governed by ICAO. It's called ICAO manual. It's the International Civil Aviation Organization. So the basically ophthalmological examination is covered in the 3 aspects: visual acuity, ocular alignment, and color perception. So for class 1, the distance vision acuity required is 6/9 or better in each eye separately, 6/6 or better in both eyes together. In class 2 is 6/12 or better in each eye separately, 6/9 or better in both eyes together. The point to be noted is there is no limit of uncorrected visual acuity and no limits of refractive error. And applicants whose uncorrected visual acuity is less than 6/60, he needs to give the full ophthalmic report, detailed fund examination with the retina specialist opinion, and every 5 years thereafter. So suppose candidates come for your ophthalmic report, the probable cause will be substantial decrease in uncorrected visual acuity, any decrease in best corrected visual acuity, any injury of eye diseases, eye injury, or eye surgery. They are frequently asked question is what is the near glasses we should wear. So glasses with the whole power is not accepted in aviation. Only look over glasses is accepted, and separate glasses for distance and vision is not accepted, as it may hampers the frequent changes of glasses may hampers the aviation environment. Contact lens is also permitted, but it should be non-tinted and monofocal, and they can put also some lubricating airdrop during the flights. So these are some aviation related drugs which are safe during flight. This is the manual from the Federation of Aviation Authority from US. So they give the different kinds of drugs which can use in the flights only. Progressive glasses also permitted. Now again frequently asked question, what type of sunglasses we use? So this UVB rays is absorbed by mostly ozone layer. The aircraft window provides excellent protection against UV radiations. However, some visible lights, the blue end of a spectrum, may come to the directly to the flight. So flight crews are more exposed to blue light than the ground air crew. So sunglasses accepted, but it should be at least 95% of UV absorbing capabilities. Very dark sunglasses also not recommended, as it hampers the instrument visualization. Polarized sunglasses also not. That's a very important question. Polarization, can we use polarized glasses? That is not recommended because it alters the changes the color of the cloud and glare from the cockpit instruments. And for photochromatic glasses, as we know, there's a lot of delay time to coming normal. That is also not accepted. So it's a very interesting one article I found that they have calculated the spectral evolution of eyeglasses blocking efficacy of ultraviolet rays. So they have shown that even the Ray-Ban glasses is only 75% block the UV rays. On ocular muscle balance, there should be no manifest frequent, adequate convergence, and ocular movement should be full and free. So this is the IAP value we take. So it's very simple. At 6 meters, everything is 666. ESO is also 6, EXO is also 6. Convergence value we take from the IAP. Now coming to the color perception. So we already know how to take it. So class 1 and class 2 CP3 up to fit. In fact, in class 4 and class 2 CP4 is also fit only, but you have to write in the only in the day time flying only. On common ophthalmological disorders, all refractory surgeries are allowed. Minimum post-op period should be 6 months, and medical fitness depends upon the visual requirement. So after the post-refractory surgeries, these are the minimum criteria. At least 6 months post-op should be there. Corneal topography should be normal. Cornea specialist recommendation or sign or stamp should be there. No post-op complication like corneal opacity or interfering with the vision. And further class 1 medical examination should be done in Armed Forces Center only. Here point is no limits in myopia, no minimum CCT cutoff values. So what we differ from our armed forces. And again, important question is when you come for the LASIK suitability evaluation in any center it comes, kindly tell that the training period might be extended because you will be downgraded for 6 months, your license might get expired, and tell your company that you will not evaluate for at least 6 months after the LASIK. What happens, they don't tell and they come to us, we unfortunately have to downgrade him. And a lot of panic has happened. My flight is, I have to take the flight and take the things from there. I have to tell DG, say, no, it can't be done. So it's a very, critical situation happened to us. ICL obviously not accepted. It is already given in the IAP. On cataract surgery, I think most thing we generally encounter is in ICAO manual, it clearly says it only considers monofocal lens, and DGCA manual, our Indian manual also say only with the monofocal intraocular lens implantation. But when we compare with the other aviation industries like CA Australia, this is Civil Aviation Authority Australia, multifocal extended depth of focal IOL instead of monofocal IOL may be accepted on case-to-case basis. However, neighboring country, New Zealand, is not accepting monofocal IOL, and they have given the percentage of glare and halos. And UK also does not, and UK shows it does not recommend or approve the particular intraocular lens implantation. So they have certain sets of questions. So if there is any problem with the questions, you require the ophthalmologist opinion. However, in USA, the Federal Aviation Authority gives, he approves the multifocal IOL, but multifocal IOL should be FDA approved. So any cataract surgery by phacoemulsion after 4 weeks, P2 status, that means PIC with QOP, and after 12 weeks, it should be full flying status. Glaucoma, diagnosis of glaucoma does not per se qualify for flying dosage. The thing is, should be free from side effects and fit to fly if the central 30-degree visual field shows mild glaucomatous loss in both eye or moderate glaucomatous loss in both one eye, other eye being absolutely normal. So I'm not speaking mild, what is mild, moderate, and severe, we all know. So this is the disposal. Ocular hypertension is PIC status. Primary open angle glaucoma, PIC with QIP. In angle closure glaucoma, if the LPI is done, fitness to fly only after 3 months and with the PIC with QP, and subsequent review only at the Armed Forces Air Force centers. These are certain conditions which not fit for flying, like glaucoma with coexisting pathology, neovascular, uveitic, and secondary glaucomas. And again, we keep troubling the retina specialist, lattice degeneration. So lattice degeneration, if anything is done, it is fit for, unfit for 4 weeks. After 4 weeks, it becomes fit, and all subsequent review at the Armed Forces Center with the VR opinion. But problem here is they have not given any, life, how much should we follow? They given lifelong. So every time they have to come with the, but our center, we give only 2 to 3 years. After that, we become fit. Age-related medical condition, it's PIC with QOP. Should be able to read and 14 at 1 meter with acceptable visual field, unfit if there is a metamorphosis on axillary. So these are the few conditions which make individual unfit for, in fact, the initial, like recurrent keratoconus, keratitis, keratoconus, ARMDs, retinal vascular disorder, intraocular surgery, glaucoma detected, juvenile JOAG, CSR, and RPs.